Hello everyone. My name is Liberty, and I am an artificial intelligence generated voice, written specifically for the documentary that you are about to watch. Yes, because in this final episode of A Journey Through Time, we will be talking about the future of healthcare. And as you all know by now, there will be a lot of AI in every aspect of our lives, including in health. But don't be afraid. That doesn't mean that humanity will be exterminated by a robotic revolt. At least not for now. In the meantime, I hope you won't get turned off by my robotic voice, because I am also learning how to speak as naturally as possible. How do I sound now?
Artificial intelligence is spotting cancer in people years before Dr. Mayhem.
Dr. Gupta is a physician AI chatbot that can give you personalized health suggestions.
Medical specialties that I think will be replaced by AI.
In a previous episode of Life in the Ward, the filmmakers traveled to the highlands of PNG together with Dr. Mola, finding out the state of healthcare centers that were once thriving in Papua New Guinea.
So here's the health centre. And here is Mr. Pitu, I think. I haven't got my glasses on, but Pitu. So Wongoy Health Centre has been, at least, a government health centre since it was built about 15, 17 years ago. So last year, the Catholic Church negotiated to take over the supervision of the health centre.
Which is a good news,
Yeah, well, good news insofar as it will now be supported. Yeah. As the government people never came, they never took any notice of it, they didn't do maintenance. So on the left is the original health centre, and it's filthy and it's run down and it's a shell. Yeah, this is the derelict adult ward. Typical health centre. When it was built, beds and mattresses and light was there. There was actually a generator. It hasn't worked for the last 10 or 12 years. It's still sitting there. So here was the slightly newer delivery bed. And the health workers tell us that they've not had a visit from anyone in the provincial health headquarters at Kundiawa ever since they arrived to work in this health centre 2 years ago. So this was the old labour ward.
Only one in there.
And there's the rusty delivery bed.
Oh my, are you serious?
Yes.
When did they stop using this? Must have been like 30 years ago, right?
No, in 2019.
This?
Yes.
Oh my gosh. Okay, all right, no words.
And on we go.
The situation at Wongoy unfortunately is not unique in Papua New Guinea, even though it has improved since the Catholic Church took over the management. But how did we get to this point, knowing that many other health centres are in a similar condition?
There was a really big upgrade of everything in health in the late 60s and early 70s because Australia was being pushed by the United Nations to prepare PNG for independence. And they put a lot of money into developing health and education in the late 60s and early 70s. We had 1,000 plus aid posts, 60 or 70% of which have closed in the last 10, 15 years.
Getting rural health to the people is really hard. It takes a lot of money, it takes a lot of logistics, it takes a lot of effort,
Yes.
and a lot more health workers, and it's a very challenging job. And sometimes it's so overwhelming that I think that also contributes to the sense of apathy that we see. So how can we sort of work together to make it less insurmountable so that people actually get the health support that they need?
Mariel Sander grew up in Papua New Guinea in the 1970s, at a time when healthcare was provided for a much smaller population. She now works for the United Nations Population Fund, and according to their latest survey, as much as 70% of health centers and health posts in PNG are now debilitated. What to do with these medical facilities is a decision that will affect the healthcare of millions of people in the years to come. But as new technologies keeps evolving, perhaps it is also time to think of something entirely new.
So those are the ones at the front and in the back. We've got our IT team, Kaylani, James, Alban, and of course the man from Melbourne that came up, Stuart.
Sarah, yesterday we had a bit of a session with Deb around all the things they'd like improved or changed, and nearly all of it's sitting in V5, or it's certainly planned in the next couple of months.
The Paradise Hospital's management team is discussing today the possibility of introducing telehealth as part of the hospital's medical services. They are being advised by Danny Lindrea and Stuart Turk from Australian-based DC2 View.
What digital health does, the more and more you get into this, it has to be real time with the patient.
Yes.
Right? So you can't put them in theatre and they're still in inpatient ward.
So, for example, some of our patients that come, especially after hours in the night, they don't necessarily need to make the trip in the night for security reasons, transportation and all of that, especially to the outpatient department, because we operate 24-hour outpatient.
At the moment, people only know about coming into hospital.
Yes.
And they don't, the services are there, it's been accessed, used elsewhere, but our people don't understand that they can be seen virtually.
So we will launch a virtual clinic ourselves and hospital ourselves. We will be the first hospital in Papua New Guinea to have a parallel virtual health facility in which our doctors are here, you are in your homes, wherever you are in the country, you can access our services and you can consult our doctors, you can get your treatment.
We can also extend it to education in terms of all the nursing schools. You know how
There are many possible formats and usage for a new medical service like telehealth, but how it could be practically introduced in a country like Papua New Guinea, knowing that it has been beneficial somewhere else in the region, especially amongst Australian Aboriginal and Torres Strait communities.
While healthcare is problematic here, it has also got a huge opportunity, and it hasn't got all of that legacy system stuff that we've dealt with in Australia. It is kind of like a greenfield. So, and then if you add to that the technology that's available now and a digital health platform, in an environment like this, it can take healthcare from where it is to quite advanced with lots of options. And I think it's not trying to get Papua New Guinea to have the best technology. What I believe Papua New Guinea needs is options on how to deliver care. It needs options on how to partner with the public and the people on the street and educate them.
I can't imagine that virtual consultations will ever be a part of ordinary day-to-day medical interactions with patients.
5 years. So when in family planning, you work with Kisim, long or some Abrus.
But I think there are small openings for effective use of telemedicine and virtual consultations, because, for example, after having the baby, the follow-ups that are very important to make sure the baby's not getting an infection, make sure the mother's lactating okay. All those kind of issues can be very easily dealt in a virtual consultation.
One of the things with obstetrics and gynecology and birthing is the length of the process from gestation to 1 month post-delivery. So virtual care offers the opportunity where people don't have to continually come to a hospital, but they can still be monitored. And if there's a problem, they can be told, yes, you actually need to come into hospital.
Hi, Sarah.
Hi, Doc.
It's been a while after the seizure. How are things going?
Things are going great. Slowly recovering, but all right. Getting there.
Sarah is a first-time mother who experienced complications during the birth of her premature baby. Today she is conducting her first telehealth visit with Dr. Paiva, a senior obstetrician at the Paradise Hospital, who is monitoring her recovery.
Wow, look at that. I know where that nose came from. Sarah was having her first baby, and things seem to have gone on well in the first few weeks of pregnancy, first few months. And then I started noticing something around about the 30th week. Baby was lagging way behind. And she also suffered from high blood pressure during pregnancy. It was very severe, in fact. And so we had to make a decision on whether we continued this pregnancy or terminated it at some point to save baby and also Sarah's life as well, because the high blood pressure was really getting to her.
My baby was born premature, and I was just hoping that it wasn't gonna come out like that, but eventually it did, and it was a very, I would say, sad, but eventually we went up to the nursery and everything. Fast forward now, coming here and staying at the house, like it's much easier to stay in the house than going back and forth to the hospital, especially for a consultation. Like we can just have it at the comfort of my home. It makes it easier, not only for me, but also for my baby who's, slowly gaining weight.
Virtual health is something new. It's new for all of us. After the COVID, for instance, COVID pandemic, that made it very difficult for people to actually access health services. But it's a lot easier with obstetrics because we have, both the mother and the baby, and they're usually well. Basically, you just want to contact them and find out how they are, and it won't take too long. Perhaps, like in Sarah's case, less than a 10-minute consultation just to find out how things are going for them. Yeah.
Sarah was able to make the most from telehealth, like many other people will in the future. But this is far from being the only innovation in healthcare. Artificial intelligence, for example, is set to play a much bigger role in medical services, and in fact, it already does.
So we have an artificial intelligence platform that's linked to our chest x-rays for TB screening in the antenatal clinic. So we've set up here to do x-ray screening for TB diagnosis. The earlier you diagnose the TB, the less damage it does to the body. And for the pregnant women, that's really important because damaging the woman's body with a TB infection can be both bad for her, but also bad for the baby inside.
In a previous episode of Life in the Ward, the filmmakers visited Gimo Island, just across the bay from Port Moresby, where patients back in the 1960s were treated against TB.
In those days, we had to give 2 years of treatment. And then we developed more effective TB drugs, which allowed us to shorten the span of treatment to 6 months. So that was good, but bad, because these new drugs are so effective They knock off 99% of the TB bacteria in 1 month or something, and you just feel normal. You feel as though you've been cured. But problem is, we can't get the people to take the drugs for the full duration of treatment to eradicate the bacteria.
Like many other diseases, TB is experiencing a resurgence in Papua New Guinea. But the hope is that the use of artificial intelligence to screen a much larger number of patients could make the difference again.
Vai me passim la door.
Yes, you're gonna
What it? So the artificial intelligence scans the X-ray, and the predictability indicating TB disease is as good as a specialist radiologist.
Sorry, you know, put down, just relax.
And it's very focused. It doesn't scatter the radiation sideways. This is a printout of the actual X-ray, and the machine marks out the lung field. Abnormal study, the heart shadows enlarged, the trachea is shifted. In the old system, we could not screen. We could only send the occasional woman who had symptoms. So that was like 1 or 2 a day. This technology can do 200 a day. It means that the women don't have to go over to the radiology department, sit in a queue for 3 hours. And besides, when women come and wait for 2 hours in the antenatal clinic here, they don't want to go and spend another 2 hours over there waiting for an X-ray.
Artificial intelligence and telehealth are just few of the new trends that are set to play a significant role in the future of healthcare. But at the end of the day, regardless of the many different options available, it is always up to the patients to make the first step, to seek help from medical facilities, and not only at a time of trouble.
I have a very strong family history of type 2 diabetes. And for the last, 6 years or 7 years, I have actually controlled my diet and also do exercise to maintain, a normal blood sugar. But, the complications are the ones that can actually cause mortality to someone who is actually suffering from that. Dr. Boko.
We have seen people with no symptom but significant coronary artery problem. The lumen gets smaller until when it gets to a significant narrowing, that is when people become symptomatic, chest pain and shortness of breath. But for some people, they don't feel anything at all.
Oh, that's good. So we're going to get it soon.
That's why it's a good thing like what doctor wanted, to come in and do an angiogram because you got a risk factor.
Okay, good. Marco, now you seeing me naked now. Okay.
It's okay. We're really been to the beach together.
If the doctor assessing the case realizes that this particular person has a very high risk of coronary artery disease, even though at the moment he might be asymptomatic, have no symptoms, an angiogram would be a good idea. But it's not like everyone over the age of 40 should be lining up to have angiograms. That would be a complete waste of resources.
I have given the medicine already.
Thank you. Yeah.
I just grabbed everything. I didn't know which medicine.
No, that's good. You did well. Yeah.
Let them do their work. Okay.
Marco, you make sure. Okay? Save our boss.
After doing all the blood tests and knowing that the blood test was okay, all my, the blood markers on control of diabetes were also always normal. I did not have any symptoms. I was not, complaining about anything, but I volunteered to do it because one of the major complications of diabetes is heart attack.
After all the routine medication was given, then he was taken into the cath lab where the actual procedure was performed. Every invasive procedure got risk. When you enter, as you move your wire, before you push your catheter in, when there is a restriction, you don't need to push. And you saw that machine that we swing around in the cath lab, and that was solving all the arteries and catheter. The machine can be now used to guide the artery all the way into the heart.
So I was actually more aware of what was happening, okay? And talking to Dr. Boko during the process, made me feel more at ease.
So the big artery divided the left, right, the two branches. Left anterior descending this way, left circumference. They look so good, huh? Look like a rugby player's artery or something. Anybody who's got diabetes for a long period of time, naturally the blood vessels in the arteries will get smaller and you will see evidence of disease. But for doctor on the left side was perfectly clean, like somebody who's got no diabetes. Excellent, very nice artery. I go to the right side, huh? Okay, the right side, it's got some narrowing there.
Oh, yeah, okay, IO canyo.
When we finish from the left and going to the right, that is when we saw his proximal artery that has significant narrowing.
That's the one. That's the right one.
Yeah. So what we try to do now is that, and the right artery was quite big. So what we did was that, because we were thinking whether to stent or not, we need to ask doctor about the symptoms. Bosman, you don't have chest pain or short wind or no gut. Okay. Those are important. So now we play story now. Any eye roundabout or this like kind? No.
I was comfortable actually talking to him when he said that I had a bit of narrowing, okay? Because I wanted to know how much narrowing is the vessels. Because I know that the diameter of the blood vessel is around about 5 millimeters, okay? And with narrowing, that means I'm coming to the stage where it can go into heart attack.
And somebody prepare the church ICPR. You feel like a balloon.
The lumen and the diameter of the blockage, we realized the doctors, it reduced markedly down to about 3.5. And we decided that instead of stent, we do a balloon and see.
Okay, balloon. This is before.
Balloon went in, we inflated, we break all those, the narrowing and atheromous plaque, the arteries, where it was narrow, it opened up so nicely. So when we put back the IVES, that is the intraventricular ultrasound scan, it revealed that the area that was blocked from 3.5, it all went up to almost 7. So it was perfectly normal artery. In there, much of the wall are all good and intact. There's no rupture or laceration. Okay, thank you. So we decided not to stent. So today you stay with us, tomorrow we'll see how things go and we should go on. Okay. All right, All right.
Having decided to undergo an angiogram was perhaps the best choice Dr. Sios has ever made. Not only it saved his own life, but it also showed the importance of having tertiary healthcare facilities in a country like Papua New Guinea.
In the past, what usually happened to a lot of Papua New Guinean patients is that they would travel overseas to just go and have a proper sort of test done to confirm the diagnosis. And that's what we are trying to actually help to actually minimize the cost to the ordinary, Papua New Guineans.
Bosman, that's Stephen Dawanikula over there, TV reporter, the NRA, Stephen Dawanikula. He was advised to go overseas, but I met him over the weekend. He said, come here. And yesterday he came, we sent him, and now everything is end of the story. Yes, please. Generally, the medical health workers are the worst patient. It's very difficult to control these people. They don't even come in for their checks, even though they know that they are sick.
I'm going through an angiogram too.
But compare them with what Dr. Sios has done. I think he is really very health conscious, and I think all of us should follow his footsteps.
These kind of interventions for the people who have ended up with complications to their bodies, of course they need to be cared for. We care for everybody. But at the same time, we must also have a focus on prevention.
Intraventricular septal wall dividing left from the right.
It's fine for some specialists, some of my peers, to focus on the group of people who've got the damage and need the tertiary. But there needs to be a group of us too who promote prevention. And at the moment, those of us on the prevention side are a tiny minority, or perhaps hardly exist at all.
I think one of the most important things is to build a bridge, a relationship with the public and the private sector. And having all the specialists in the public sector coming in, provide the specialist care, it helps to actually bring in the cost to patient at a reasonable level as well.
Eddie, Bosman is here. We just want to put the TV on for the camera, for the TURP there. So
they're bringing out the gowns.
So we'll go inside and we'll show you the...
I'm camera shy because of him.
No, we're inside. We're already there. So when the prostate enlarges, because of changes in the hormones in our body, as long as you are more than 50 years old, hormones change, and that leads to the enlargement of the prostate gland. One thing about our machine, the TURP, is the one where it resects and also coagulates same time. And it's really good, yeah.
Public sector, you have the strength of a bigger team usually, more experienced people, and you also have the advantage of caseload. But the more cases that you do, then the more experience you get with the difficulties that can occur with this, what you're doing. But then you can take this to the private sector when there's the crossover of staff. And these kind of collaborations can be beneficial and useful.
Building a bridge between the public and the private sector, this is something worth thinking about for future generations. But what approach should this country choose? And how could digital health facilitate this integration?
So there's lots of different models, and it's just, you know, getting the people and the leaders of this country and these hospitals and this healthcare in a room to start to work this out. What can we do and how can we do it with what we've got? But my message is, don't worry about the technology anymore, because it's there. That has been, you know, effectively a 20-year journey in Australia. To go from there to there, these guys have done it in, 18 months. And now they're set to do real impact of healthcare in Papua New Guinea.
I think we should take on innovations and sophisticated tertiary level healthcare that it's possible to do well. And then there's the issue of benefit for whom? Benefit for the urban minority, or benefit for the rural and poor, the rural majority and urban poor? And that mix is really difficult to get right when you've got limited resources.
Finding the right balance seems to be a good advice. But even with limited resources, there is a lot that can be achieved through new technologies nowadays. Effective measures like telehealth and artificial intelligence, for example, especially when applied to practical projects, seem to have a role to play in a country like Papua New Guinea. At least that's how I feel. What about you?
So after Danny and Stuart actually left, it took them about 2 weeks for them to produce a report and send that report back to us, okay. I have had a look at the report, okay, and I've seen the infrastructure to provide an efficient digital health service is already in place, it's solid. So I am now in the process of, retiring from active clinical duties. The other thing that I have is just the cramp and the stiffness. So I could start with my own province and put in the telehealth to the provincial hospitals in New Ireland. And if they can learn something from it, then we can easily do that,
Well, easily, I don't know, because in PNG nothing is very easy.
Nothing very easy in PNG, yeah. It's a dream.
Good afternoon, students. This afternoon we are having a very special visitor with us here, and listen carefully and watch and be attentive to what he's going to tell you.
So I was a village boy just like you. So I grew up in a village. I grew up at Pakinsala village. I didn't have any idea where I'm going to end up. The message is, that it doesn't matter where you are, how you grow up. When you dream, you can make it into reality. So this is where you start dreaming, okay? You start your dream now.
I want to be a doctor. I want to be a pilot. I want to be a lawyer. I want to be a doctor. I want to be a pilot. In my future, I want to be an engineer. Pilot. Soldier. Civil engineer. In my future, I want to become a scientist.